So while we're see if we can get Haley in this part, we have a poster back here. Are you guys ACLS certified, just BLS certified? Okay.
The BLS, we have a couple people that are
Okay.
certified for.
Okay. So ignore the middle part of that poster, because that's not gonna mean a whole lot.
Yeah.
But the biggest things, I think, you know, if everybody on this floor or in this hospital, this unit is at least BLS certified, everybody can start the initial steps of this simulation. And that's what's really important. You know, I've been to other hospitals where, you know, certain people in the unit are ACLS, certain people are BLS. And again, that just goes to show we might have to divide and conquer and maybe switch up some roles, but everybody has an opportunity to participate in this patient care, because everybody can do compression. Everybody can slap some pads on it, right? So there's a lot that can be done, and even people that aren't BLS certified. So if you, I don't know if you have like a secretary somewhere that responds to see if they can help for any reason, they can displace the uterus, right? So we got to think about some of those things and what role they might have, but everybody can have a role in here. So that's kind of what this poster is really touching on. The first thing is get hands on the chest. That's number one. So mom goes down, you check for a pulse. If she does not have a pulse, we don't move her, and that's really important. I know Miranda was talking about that. Let's talk about where your ORs are. Where's your OR? Down this way? That way, straight down, okay? Okay. So especially for you guys who have a call time, right, to get people here, it's not like you have people readily available to start in the OR right away. You can go back and open things up, but what are you going to open back there that you can't open in here, right? And like Miranda said, really all you need is a scalpel. I would also add some clamps. And that's about it. Otherwise, there's nothing that you have to have from the OR to do this delivery. So we, at our facility, we have precip kits. And it's got a couple different clamps. Kelly's usually in there. And a cord clamp, I think, is also in there. I really don't need anything else other than those few clamps and a scalpel. Some scissors, sure. That I can also put the cord with that scalpel. So really just a handful of things that I'm going to need. 3 to 5 minutes is the recommendation. It kind of depends on who you talk to as far as what your time frame is. Some people say I have a 4-minute rule. If we have not achieved ROS by 4 minutes, we're going to start that resuscitative delivery in the room. Some people say it's a 5-minute rule. If we have not achieved, you know, ROS within that amount of time, I want the baby delivered by 5 minutes. That's our goal.
ROS would be, I'm assuming,
Yes. Well, any good, yeah, something that's producing.
Yeah.
Yes. And that's a good point, because sometimes our monitors are going to show that we have a rhythm, but is it perfusing? So we have to make sure and check for that pulse, because it will be pulse electrical activity. Not in the room, but you should have one on your code card, right?
Yeah.
Oh, yeah. So when you bring that code card in, that you can hook her up, and it will you know, have a rhythm to analyze, which at least it will tell you whether or not it's shockable. If there is, you know, no kind of electrical activity in the heart, there's nothing to shock, right? So in that case, it'll say CPR. So 3 to 5 minutes. Some say 4 to 5 minute rule, and it really just depends on how you want to think about it. If you want to think about when to get the baby delivered or when you need to start. And really, this is a guideline. It's the recommendations. If you don't have a doctor in house, there is no nurse on the floor that should be picking up that sample. It is not within our scope to do that, right? So in that case, you just keep going until you have somebody here. Now, an ER doc, they're not going to want to, but they could do this for us. Nobody wants to do this delivery, but they could do it. Oh, okay, she's back. So those are the things that we want to kind of think thinking about. And like she said, it should be kind of one of those things in your mind. If you see the patient is having some challenges, start thinking through what could be going on. And we can rule out several things pretty quickly. Like she said, abruption. That's not typically going to be just an all of a sudden thing. There's kind of a progression to it, and signs and symptoms that she might start experiencing: pain, heavy bleeding, things like that. You can have concealed abruptions, but she's going to have some signs. Usually the pain, vital signs are going to start trending, that kind of thing, before we see that immediate collapse.
Hi, Haley. Sorry about that.
That's okay. Thanks for letting me on.
Yeah. So since we have you back, I'm going to go ahead and play the presentation.
Okay.
And it'll kind of take us through the really down and dirty with Afe. And then we're going to do a simulation in here. I am happy to try and keep you on if you want to watch, but I will also be recording it separately that we'll be able to send out to you guys as well.
Yeah, that's totally fine. I'll just stay on, and if for some reason it's not, best, I'll just watch the recording, but don't feel like you need to do anything differently.
Okay, perfect. All right. Bear with me. I'm not super savvy with Zoom. Can you see my screen, Haley?
It says that it's still trying to screen share, but it hasn't uploaded yet.
Okay. As I'm sharing.
Okay, there it is.
Got it? Okay.
Yep.
Here we go. And play. All right.
A special thank you to the Afe Foundation for
Can you
their
hear that?
assistance with this presentation. Today we'll be talking about how to recognize early warning signs and symptoms of amniotic fluid embolism. We're going to look at the classic Afe syndrome triad and differentiate between proactive and reactive treatments. Amniotic fluid embolism has become more common in recent years for unknown reasons. The graph here represents percentages of pregnancy-related deaths in the United States as reported from the CDC in 2011 to 2016. Amniotic fluid embolism comes in at 5.6%. Of patients with AFEs, 50% of them die within the first hour of the onset of symptoms. In survivors of the cardiorespiratory phase, 50% will develop a coagulopathy. Most survivors have neurological deficits. A recent study in 2017 indicates a maternal survival rate of 15% and a neonatal survival rate of 50 to 80%. Of those that survive, 85% of moms and 50% of babies will likely develop neurological impairment. Despite its vast history, there's a lot still unknown about AFE. In 1926, the first cases were recognized and reported in Brazil. In 1941, Steiner and Lushbaugh defined AFE based on post-mortem findings of fetal flames in maternal vasculature. In 1948, Eastman is quoted saying, "Let us be careful not to make this a wastebasket for all cases of unexplained death and labor." In the 1980s, Dr. Stephen Clark began his registry, increased diagnostic tools, and review of cases began to disprove previous theories. In the 90s, Dr. Clark proposed a new name, Anaphylactioid syndrome of pregnancy. Despite its greater relevance, this name was not widely adopted, and the registry ends. In 2008, the Afe Foundation and Afe Registry were established. Our general understanding is that the typical presentation includes the classic triad of symptoms: hypoxia, hypotension, and coagulopathy, but there's a lot that still remains poorly understood. In fact, 30 to 35% of cases are incorrectly diagnosed. And this is because we don't have a clear picture of the clinical presentation. There's other differential diagnoses or even ethical dilemmas that play into that diagnosis. We know that AFE is very unpredictable, rare, has a very acute onset, but unfortunately there is a lack of a gold standard for diagnosis. The previous theory of cause is that amniotic fluid is forced into the maternal vasculature. Cellular debris obstructs the pulmonary arterial flow, leading to hypoxia. In 2018, this article was published that suggested a different theory of cause. They studied specimens from 30 women at term at the time of rupture for both vaginal deliveries and C-sections to determine the concentration of amniotic fluid squamous cells in maternal circulation. Ultimately, they found that even if the entire volume of amniotic fluid were transferred into maternal circulation, and each of those squamous cells did in fact obstruct a pulmonary alveolar capillary, these obstructions would still remain undetectable. They concluded that the pulmonary effects of AFE are associated with an inflammatory process rather than a physical obstruction. We also know that fetal antigenic materials often pass into maternal circulation. So why do some people have such a dramatic response and others not? This leads to the current theory of cause, where passage of amniotic fluid into maternal circulation leads to an abnormal maternal response and an immune reaction. This is an important distinction because this may explain why the same treatment leads to drastically different outcomes. 80% of the time, patients are going to present with the classic triad of symptoms: hypoxia, hypotension, and coagulopathy. 20% of the time, there may be an atypical presentation. It's important to have a strict criteria for definition of AFE. Administrative data has shown a higher incidence with lower mortality. However, upon clinical record review, we actually know there's a lower incidence with higher mortality rates. There are currently no recognized risk factors with sufficient scientific validity to warrant any alteration in the management of labor and delivery in order to avoid or reduce the risk of this condition.
I know, right?
The timing and onset of AFE symptoms occurs primarily during labor. 20% of the time, it occurs during C-sections, and 10% of the time immediately postpartum. There are a few cases of AFE onset occurring during other procedures. These are the recognizable signs and symptoms of AFE. Respiratory distress is reported in 93% of cases. 87% of cases report cardiac arrest and 83% coagulopathy. These signs and symptoms and central hemodynamic changes are similar to those seen in cases of anaphylaxis, SIRS, and septic shock. In its most classic form, a woman in labor or shortly after delivery sustains acute dyspnea, desaturation, sudden cardiovascular collapse, followed by cardiac arrest and/or coagulopathy. Hypoxemia causes 50% of deaths that occur within the first hour. Permanent severe neurological impairment or maternal brain death can result from profound or prolonged hypoxemia. The hemodynamic instability is both complex and variable. Initially, we see pulmonary and systemic hypertension, which leads to profound left ventricular dysfunction. The treatment of AFE is really going to focus on that classic triad: hypoxia, hypotension, and coagulopathy. We will support her by giving supplemental oxygen, supporting her blood pressure with volume and vasopressors, and giving blood products and hemostatic agents for coagulopathy. There have been some case reports of LVAD and ECMO use in AFE. We do not currently offer these services at Overland Park Regional, but do have options for Impella and intra-aortic balloon pumps. I would like to take a moment to talk about the proposed Aok Therapies for AFE. It's important to recognize that there are no studies that have been done or will ever be done verifying the effects of these treatments. It would be unethical research to study this alone. This is strictly an anecdotal therapy and should not result in the delay of your code management. The only validated management of AFE includes management of the classic triad of symptoms and following the management of a code as recommended by the American Heart Association. This includes effective CPR, defibrillation if indicated, and epinephrine administration. The AHA removed atropine from the cardiac arrest algorithm in 2018. It currently only remains on the adult bradycardia algorithm. This is an example of a flow chart from maternal arrest and suspected amniotic fluid embolism. The first step being high-quality chest compression. We're going to anticipate a resuscitative delivery, activate the massive transfusion protocol to treat postpartum hemorrhage and DIC, maintain her blood pressure and hemodynamics with volume and medications, and get a bedside transthoracic echocardiogram to help visualize the structure and functionality of the heart. CPR on the pregnant patient is going to be the same as with a non-pregnant patient with only two exceptions: left uterine displacement and the 4 or 5 minute rule. With multiple people present, left uterine displacement is preferred over a 30% left tilt. While a patient is in a supine position, this results in compression of the vena cava. When tilted 30 degrees to the left, you experience reduced compression force and still compression remains on the vena cava. The heart shifts laterally during that tilt. Positioning of the hands should remain the same as a non-pregnant patient. Previous recommendations suggested moving hands up on the sternum, but there is no data to support this recommendation. Evacuation of the uterus by 5 minutes improves maternal and neonatal outcomes. Perimortem C-section should occur at the same site as the cardiac arrest. Do not waste time trying to move the patient to the operating room. CPR efforts are less effective during transport. If a patient is found to be completely dilated and the infant is low enough in station, assisted vaginal delivery can be considered. Defibrillation has long been a concern during maternal resuscitation. It is unlikely to pass much energy to the fetus in utero and is unlikely to have arcing to the fetal monitors. In fact, during resuscitation, attention should be solely on maternal status. Attempting to evaluate your fetal heart rate during this time is not helpful and may actually delay maternal resuscitation efforts. No medications should be withheld due to concern of fetal exposure. Epinephrine has been shown to change cerebral and myocardial perfusion. Vasopressin has strong vasoconstrictive properties. Historically, there's been concern for other ACLS medications and fetal exposure. For example, amiodarone has an extremely long half-life. However, in 4 minutes, it is unlikely that you would get to the point of these medications during your resuscitation. Risk-benefit should always be weighed. Most medications have a small enough molecular weight which allows them to cross the placenta. However, maternal well-being is the priority, and fetal well-being is directly related to your maternal condition. Initial lab evaluation is very important for the treatment of AFE as well as ruling out some differential diagnoses, so don't delay. Fibrinogen is very important to diagnose DIC. Remember that fibrinogen is normally elevated in the pregnant or newly delivered patient, so a normal value is actually low. PT, PTT, and INR will not be abnormal unless your fibrinogen has dropped significantly. D-dimer is not particularly helpful for the pregnant or newly delivered patient due to the normally elevated levels secondary to their hypercoagulable state. The red top clot test is a quick way to evaluate for coagulopathy. Draw a sample and set it aside for 5 minutes. If a hard clot is formed at the end of that time, your fibrinogen level is likely to be greater than 150. If you have a semi-solid clot formation, your fibrinogen level is likely to be in that 100 to 150 range. If your sample remains liquid and no clot has formed, Your fibrinogen level is likely to be less than 50, and your patient is likely to be in DIC. The diagnosis of AFE has traditionally been made upon autopsy after death. There's currently no gold standard for diagnosis. Based on what we know about the syndrome, the diagnosis is primarily based upon the clinical observation, the classic sudden triad, hypoxia, hypotension, and coagulopathy. Several investigators have proposed a more specific lab or autopsy finding. The search for specific histologic or lab markers continues. This condition remains primarily a clinical diagnosis of exclusion. The Igfbp1 protein is an insulin-like growth factor binding protein. This is being researched in Afe survivors. It is being found to be in much greater concentration in women with AFE than those without, those experiencing postpartum hemorrhage, and those with uncomplicated labor and normal pregnancy. It's important to be aware of support groups and resources available to patients that have survived AFE, families that have lost loved ones to AFE, or clinicians that have cared for these families. The Afe Foundation is a unique coalition of affected families, respected clinicians, world-renowned researchers, and engaged advocates working together to accomplish 3 key initiatives: advancing research, promoting awareness and education, and offering support to families. The Afe Foundation represents over 1,500 families with outcome-specific support groups. They have licensed clinical social workers on staff and a 24/7 crisis line. They offer support to clinicians, helpful guides for all outcomes, and annual training for advocates. They've partnered with several professional organizations to promote education. They've participated in clinical meetings, grand rounds, continuing education courses, online webinars, simulations and drills, and even podcasts. The Foundation strives to advance research. The Amniotic Fluid Embolism Registry is composed of over 200 self-reported cases and is the largest database of AFE cases. It is the basis for clinical research, specimen repository, and is the foundation for published papers on diagnostic criteria, management, and reproductive outcomes. The Survivor Clinical Summary Guide can be found on their website and aids in greater patient and family understanding. It summarizes significant aspects of treatment and the clinical course of events. It also assists in continuity of care and minimizing the triggers associated with retelling of the event. The Afe Survivor Guide is also available online to aid women and families through their journey of healing. At this time, I would now like to welcome an Afe survivor who will share her story and answer questions.
Here, I'll share.
Okay.
So they essentially don't know what causes it. It's just fluid, amniotic fluid that somehow gets into the circulatory system and causes collapse.
Yeah.
But they don't know
So
why it causes collapse.
that's correct. Haley, I'm trying to get off of the shared screen. Hold on. Maybe just pause it.
Because obviously pulmonary is the clot that actually cleaves stuff.
Right.
So this, they're like, it's so they're thinking it might be inflammation, but the body's responding to this, essentially foreign substance in the vascular system. That was 3 minutes ago, so it could change. Are you feeling like
There we go.
Oh, yeah. Yeah.
Okay. So yes, so Erica was asking about does it, the question was, we don't really know what's causing it, and that's true. What we do know is the study that was shown in that presentation, it is not uncommon for amniotic fluid or debris, things like that, to actually pass into maternal circulation.
Yeah, that's what I thought it was saying.
Yes. What's weird is that some women are reacting to it and some
Okay.
women are not. So
Okay.
they're trying to figure out what is it about these specific women that they're having this response. And they do think it's more of an immunological response, inflammation, kind of like an anaphylactic
reaction.
Yep,
Okay, that makes
reaction
sense.
versus actually having a physical obstruction
Okay.
causing like an embolus.
Right. Okay, that makes sense.
Yeah.
They weren't super clear when they were talking about. I was like, we're talking about cells from the fetus. So
Yeah.
I'm assuming it was that the amniotic fluid thing. So okay.
Yeah.
Because with the actual term, it almost sounds like there's a clump of fluid, almost like air
Yeah.
in your IV. You know what I mean? Like that's how it makes it
I
sound.
know. And they tried to change the name. I was talking about that on the
To the
presentation as well.
that one, yeah.
It just didn't stick. Nobody
Right.
like took it and ran. They just were like, it's Afe.
Right.
So
Yeah.
it's kind of, that really didn't take hold, but yeah, that
Right.
name can be misleading a little bit.
Right. Okay. Yeah. Thanks for clarifying.
Yeah.
that.
Haley, do you have any specific questions regarding that information or?
I don't think so.
Okay, great. We've lost half our group in here.
Yeah. It's really intense today.
Yeah. I am happy to run the sim. I don't know if do you have anything that's going to be calling your name soon?
No.
Okay.
I will just be a third set of hands if they need it.
Okay, got it. If you think that this is going to be over soon, I mean, I'm happy to wait. Okay. Haley, what are your thoughts? Do you want to hang out or do you want me to just record it as I had originally planned? I don't want to take up too
You
much of
can-
your time.
Yeah, let's just record it. That would be fine
Okay.
if you're okay to do that.
Yeah, thank you so much for joining and thank you for hopping on multiple times. That was,
Of course. No, I
Yeah.
appreciate you making it accessible for Zoom.
yeah, absolutely. All right, well, thank you so much. I will go ahead and
Okay,
end
thank
this
you.
then. Yep.
Okay, bye.